chairpersons for this session. Dr. Narhari. Sir is working as an assistant professor in AIM, AIMS Mangalgiri. Dr. Shashwati Behra. She's working as an assistant professor in AIMS Bathinda. Dr. Subhash Chandra Subudhi is working as an assistant professor in SCB Cuttack. Our first presenter is Dr. Anthony Charles Robert. Dr. Sahana Gurulingaiah.
Have the slide, please. Wonderful. Good afternoon. Coming to the back end of the day on a hard working day. And I'm still glad to see so many youngsters here. When I was putting the title for this, I said when we say building resilience among young pediatric surgeons, how do we define young among pediatric surgeons? Because it's not somebody in the conventional sense. By the time we start working, we are 40. By the time we reach some amount of reasonable excellence, we are 50. So I think anybody below 70 should be termed as a young pediatric surgeon for this talk. I think and it's good to see all three young chairpersons on the stage also. Okay, so this is something that Dr. Sahana and I both feel very passionately about this particular thing. And I must tell you, Dr. Sahana is on a full trip across India. She addressed a similar thing, a whole day workshop in Mangalore. Then she flew to Delhi. From Delhi, she's flown here. So I'm very proud to introduce her to this audience. Okay, so that is who I am. That is Dr. Sahana. So she's a associate professor at Vaidehi Medical College in Bangalore, and what she does for wellness is something which is a passion, which is not part of her job description, but she really invests a lot of time and effort into this. Right. So isn't something like resilience a very individual thing is the question which most of us ask when we hear. If you see a session like this, most people will not attend. They will say, this is not for me. This is not relevant for me. And it's something that is not my problem. Also, the danger is whether people start to think ye to fad hai, it's just a passing fad. Maybe for next 5 years, people will talk about this, then they will talk about something else and they will move on. That's another big red flag which comes. And most importantly, is it even relevant for me? How many of you feel that it's relevant for you as an individual? With a show of hands, how many of you think that is actually effective? I'm so happy to see two hands go up in the audience. I'm really happy. Oh, then somebody heard me. That's good. But it's just, let us see whether we should actually care about it. Is it worth even thinking about this? And should we actually do something, or is it something which comes with age? Will become better and better. I'm sure Dr. Kuril will agree. With age, it doesn't become better and better. It actually becomes even more difficult if you are not prepared for it. So this is the starting points where I wanted to come from. So I'm only giving the background for the talk. Dr. Sahana will do the meat of the talk. Really happy. And the bigger resistance is we are surgeons, right? We are surgeons. As we say, we are surgeons. Okay, we are not weak people. All this is for the maybe for the physician. It is maybe for somebody else, and it's not for us. Can you look at the person next to you and tell them you are at risk for burnout? Can you just look at the person next to you, point your finger and tell them loudly? Someone you can see across the room. Can we do that? Just on count of three, turn to the person next to you, left or right, and say, you are at risk for stress. Let's try that, okay? 1, 2, 3. Let's try it. Okay, very good. We heard some sound. Now can we try a slightly different exercise and say, I am at risk for stress? Absolutely beautiful. Silence in the room, right? You see how easy it is to always look at this in the context of somebody else and never for us. It's a practical example, and that's true for most audiences where we will go through. And after all, we have all got character, right? We are surgeons. Surgeons, life has given us a separate standing We are next to God is the surgeon, right? And pediatric surgeon sometimes feels like that. These are the mental barriers which inhibit us, you and me, from strengthening ourselves. Okay, that's why there is a big but there. Yes, we are like God, but we are at risk. Is this whole thing real, or are Robert and Sahana just here talking about some imaginary condition and imaginary thing? No, there's enough evidence for surgeons having these issues. And it's not like 5% or 4%. Can you see the statistic there? I encourage you to search for this and read it. A lot of articles and good studies, systematic reviews on burnout and surgeons. That is, you know how our evidence thing goes, right? Today, systematic review is all the craze. So there are even systematic reviews on this, and the numbers are big. 30%, 40%, 50% of the surveys coming back are showing that each individual is having something there. So that's something for us to introspect. This is serious business. And when it hits you as a surgeon, as an individual, your friend will not know. Your family may not realize. Your department definitely will not recognize, and probably your department won't even care, if I know most departments. Right? Therefore, it is important to see that there is growing evidence that is the real problem. And it's true for all of us. A little personal anecdote, it hit me when I was close to 50, right? So until then, I thought I was an extremely happy, carefree guy. Most people who know me also think of me like that. But when it hit insidiously and very slowly. If it can hit me, it can hit anybody, right? All right. So like I said, burnout rates and it's actually higher the younger your age. It's an inverse relationship. The older ones somehow seem to have coped and come up, but both in the trainee phase and there are studies about moral distress and training distress in pediatric surgery PGs from Southeast Asia as well, which show a very high number. So it's something for you to be sensitive about. What is one of the biggest problems which causes this for us is patient complications. Every complication which happens when I operate, or worse, when a patient dies, right? If I don't know how to be sensitive to what's happening to me, it is something which adds on to my burnout and my stress. And this is a true thing. Anecdote, I was in St. John's at that time. We had operated on a renal transplant. Fellow went home, came back, rejected. We transplanted again. As you know, donor parents. So once from the father, once from the mother. So high stress situation. Went into sepsis and he died. His name was Karthik. So then, of course, there's a lot of mourning going on, even for the team, because he was there for so long. Then I went off to Australia. I was in Sydney at the Children's Hospital. Sometime in September, I would get a call from the parents. The first year I had still had my old India number. So the parents called and they said, "Today is the day our son died." And I used to feel so stressed out listening to them because somewhere in my mind I felt they were blaming me for the death. I said, "They're calling me and reminding me that fellow died." Next year, I changed my number anyway. They still called on that same day and they would cry on the phone. They would be remembering him and crying. So this was getting to me. And finally, I said, "Can I speak to the father?" And then I was a little harsh with him. I said, "Why are you calling me year after year? I know it was a bad thing. Why are you calling me?" And what they said really broke me because they said, "You are the last guy holding my child's hand. So when you talk to you, we still feel connected to him." Their whole perspective was different, but it broke me because that's when I realized that the cost of losing a patient also can still hit you years later, and something for youngsters as well to be sensitive to. It is something which is bound to happen for us in our line of work, that complications will come and patient loss will come. And this can lead to emotional exhaustion. How many of you have found amazing support from your peers and your department when there has been a major complication which you're directly responsible for? Yes, somebody else in the audience. And I definitely had one. Again, anecdote, because I think this topic is better told with anecdotes. I had just come back from AIMS Delhi, full on fire, best institute in the country, and done very well. So I can do any surgery. There was a pure atresia. I did a feeding gastrostomy for simple surgery for a AIMS trained. Third day, fourth day, child deteriorated, and we went back in because child was gone gross sepsis, and the button had slipped from the mucosa into the submucosal space, and all the feed was going in the wall of the stomach, peritonitis. Baby died the next day. I was crushed because I had gone in with this big gungo feeling, and some thoughts will come. I will never operate again. I am not good enough to operate. I killed this child. No, all these words came, and I refused to go back to OT for 5 full days. Dr. Ashley DeCruz was my boss at that time. For 5 days, he didn't talk to me because he realized I wasn't in a listening mood. Fifth day, he came and sat in my room, just sat there, held my hand, and said, "You have to get up and come back and operate." And I told him, "I killed you. I killed this baby. I'm never don't trust me again." All kinds of stupid dialogues which come in our heads because we are human as well. And I remember him hand holding me, taking me back into OT and say, "You have to get going." All of us are not lucky sometimes to get this kind of support. But my challenge to you is, can you be that support for somebody? Because complications will come to us. If you've worked long enough, you've seen every complication in the book. And also the other pressure which comes is from our need to emulate or to compete, especially when you come out into the real world of private practice. In an institution, you're competing with other institutes or private practice. The unreal pressure which is there, because that person is doing so well, I need to do this. Chandrasekharan is publishing so many systematic reviews, I better learn how to. And that's what half the audience is sitting upstairs learning how to write systematic reviews. Yeah. So the pressure to compete is very high. So this is just the background for me to figure out that and to reiterate that this is not a psychiatric disease. Not this is not something which can happen to mentally ill people. It happens to us. It happens to surgeons, and it can have serious consequences. Serious consequences, right? It can lead into mental health issues, lead into depression, lead into addiction. All of these can happen, and like we already did that experiment, it will affect others, is what we believe. It will affect us, is something which we are resisting. When you say burnout, in our logic, we are used to burning tissue, but you can see there the surgeon themselves are burning. So make sure that you are not falling trap into this, especially thinking I am immune, I am a superhero. Okay. And one thing to avoid this, especially for the youngsters, what has worked for me are little physical things which can happen, especially prior to surgery. I used to be a religious person. I am not very prayerful and religious now, but I still use the time when I'm washing my hands for those 3 minutes to ground myself, to get into a zone before you operate. And there are days I don't do this. There are days I'm already angry, and those surgeries, as I'm sure the seniors will attest, those surgical procedures are tough. You lose your cool, you lose your way, and you come out feeling even more exhausted. Whereas if you go in grounded, it is something that and definitely seek professional help when needed. You've heard enough of boring text slides from me. I'm handing over to the lady of the day because she comes from a very practical point. So we are doing it together. So you might still get some interjection from me, but Dr. Sahana, over to you.
Oh, well, I mean, I've heard that all of you are great pediatric surgeons. I'm very grateful to be here. I'd just like to take all of you a little back in time where we spoke about what's happening in present, and we heard from Sir of where you stand as pediatric surgeons and how much it is stressful and how what do we mean about burnout and how complications are very difficult. But just going back to a few years, I just want to know what this picture would say. I think if I just want to take literally a few people a decade ago, a few of them 20, 30, or maybe 4 decades ago, we all came into med school for a reason. If anyone can say what was their reason for joining med school way back when you were 18, joining MBBS? Anybody? To help people. So the most common answer is to heal, to help. So that it was driven to us that it's a very noble profession, and healing and helping others is the root cause why we all joined when we were 18. And easily from then, I think for pediatric surgeons, at least not for the physicians, it's a easy 15 years from there. It's 5 years of med school, and then 3 years of general surgery, and then 3 years of super specialty, and then a few couple of fellowships here and there, or going a different country and coming back. easily you would have just invested 15 years of hard work in studying and not earning before you started off as a pediatric surgeon. So, and during that time, so you just had only your studies in front of you, but concurrently, when in your journey of those 15 years, it's most commonly what happens is in those 15 years, most of you would have chosen to have a partner. You'd be married, and then maybe in those 15 years, you would have had a child or is planning to have a child. That's the phase. And by the end of those 15 to 20 years, it's very unlikely or quite impossible that we don't have a story of our own. We all have a very heartbroken story where it comes to a very difficult professional life or a difficult personal life or some story where that's where we are at the ending of our just finished education and the beginning of our career. And so at but no matter what is driven with us behind is it's a noble profession, and we are doctors, we need to do good. It's a very service oriented profession. And during the phase of even including me, one of the words or phrases we learn is, I think, the phrase which I dislike or is the work life balance. So it's very common. Each of us would have heard, oh, and we at one point of time think it's work life balance is a great phrase. We all need to know this. We all need to understand this. But that's the place where we go wrong, where we still treat work as one side and personal life on the other side, and we try to find a thin balance of what is work life balance. And very unlikely, if you have a target like this on a daily basis for the next 20, 30 years, it's very unlikely you will not fall. You're going to fall because you can't finally balance on a daily basis. The whole idea is you have a concept of work life integration, how you can improvise it, or rather learn from what we have to unlearn and relearn. I also learned this phrase of work life balance, and it clearly doesn't work. So the earlier you feel you can feel work life integration is where you can actually make a difference, where it is taught very young, way back when you're starting your med school, where work life integration has to be taught, and then you go on from there where you actually don't have to really burn out before you realize. So coming to that, but the hard reality is this: it's already happened. Each of us have spent easily a decade, two or more, and this is the reality. So there is already a principle of we are exposed to suffering. So what we are exposed to suffering is the pain of the patient or the empathy that we have already given for so many years now, which is already drained us. So it's quite unlikely that we don't realize it, but the empathy and compassion what we have given, we're exposed to the suffering and pain of a lot of patients and those attenders. And we're also taught of great things like emotional suppression. Whether we consciously use this word or not, emotional suppression was what we go through. A simple example being, you're supposed to be resilient doctors, but cannot show your weakness. That's one thing about doctors. You're supposed to be extremely composed, so you cannot show your weakness. You're supposed to be very compassionate, but can't take it home, because at the same time you cannot share it in a place and talk more about it, because people will think, oh, maybe you're weak or maybe you're not good enough. So it's very unlikely that you will succeed on grounds like this. And to add on to this, we have the hidden curriculum, and also what we have as moral distress. So what do I mean by moral distress is, in my stage of life, so I have a hierarchy system where even if I know something would change the system or the patient care for something better, but you're bound to do this because the system or the protocol speaks this. So that's also a moral distress what we have on a daily basis for our patients. And also the last being a chronic stress. So I think if you look at the bureaucracy of the country, or including the hierarchical system of medical profession by itself, we all will accept, or even the administration. For the heads, it may be the hierarchical system or bureaucracy of the administrators, where you have to run the healthcare system like this. So in that process, we the thing what we assume is we are caring, but I think on the grounds where we've already crumbled, the foundation of how we started to wanting to be caregivers and providers, we don't realize we are already, the foundation is now crumbled, or rather you're already crumbling in that phase is where we actually need to realize that this is the reality. So, what is the next best thing we do? Or we go into a phase of this is the autopilot mode. The autopilot mode is you don't even realize, you will just start treating patients like no more their names. It's like bed number 21, bed number 47, or patient number this. You start naming patients. You don't have a connect anymore. You just see patients after patients because you just want to finish a list of patients and chart, and then you want to go home. Then you have a to-do list where you just want to complete your work. And then over time you're very irritable. You're no more listening to the other person. You become a person where you only want to tell the other person what to do, and you might as well better well do this, and I'm a senior, I'm just leaving. So you're breaking all your personality relationships where you're no more warm, you're irritable, you're just treating beds and charts as numbers. And that's the phase where each of us don't realize that we have lost that part of a doctor as us. And that is the phase of burnout. And we just want to, more than resilient, being resilient, we come to a phase of just being, I want to just survive or sustain. This is the phase we go into. And it so happens, again, we talk of midlife crisis and so many other things, because this all a phase. I'm just taking each one of us where we would have definitely gone through. So then we think someone would have introduced a word called resilience to us again. It's not that we have never heard it before, but whether we've practically been through that in a way it has actually healed us is the question. So the we do have friends or uh, colleagues at workplace. So the best thing we do is try to share with a friend that this is happening to me, and maybe this is very difficult to manage. This HOD is very difficult. This administrator is very difficult. And what do I do? I'm not doing well in my surgeries. Are the discussions what we have? And then the it does happen, we get some help. The friends do help, colleagues do help, and try to find a solution. But we don't realize that it's a very temporary solution, because it is just coming from a place where a friend gives you a suggestion out of not much logic, or it's experience sharing. Okay, I did this, it worked for me, so maybe you'll do this, whether it's for a personal life or even a professional life. So you just share experiences, and then you try to cope from it, just to go into two different phases again, to fail even more miserably or to become an extremely difficult person, where you go into the do not disturb mode, where you completely become a very weak personality of being like, I want to isolate myself and I just want to do things my way. Or you have a very different coping mechanism, being extremely arrogant. It's like, no, I cannot fail. The phase of non acceptance, where I cannot fail, I am better than this, then so you don't have to even give me advice. All your advices are not working. So you don't take it as something is still wrong, but you'll be like, I can figure out the solution myself. And then we you just go into a phase of being extremely arrogant, then you make more mistakes. So I think I'm just trying to reiterate a path where most of us would have gone, or seen the juniors go through. So in that concept,
When it
I'm
comes to the, sorry,
yeah.
when it comes to this do not disturb board, which we see there, each of us has our own do not disturb board, which we carry around. One of the boards we have is to appear, like she said, very strict, especially if I'm the senior, or to appear extremely jovial. I use jokes as my barrier. So when I'm joking a lot, my wife knows that I'm really struggling, right? Or we are the life of the party, right? Or we use some other method of coping with it, whether it is alcohol, whether it is whatever it comes to. Those are our do not disturb boards, right? Which come in. And because we feel that we should not show our weakness, that's human. Like all of I go through it, and I'm sure most of us will at some point wear this. In fact, there's an old Simon and Garfunkel song where he says, "I've built walls, a fortress steep and mighty, that none may penetrate." And I think for all surgeons, we've all built our fort and behind which we hide and we do our work. You can listen to that song; it'll be really good. Back to you, sir.
Thank you, sir, for that. So, in with that background for what we have already become, so we might talk a lot about things that we are present state, but this is the reality of exactly where each of us have spent so many number of years, then tried or had a fall, and then tried to cope a little, and just to fall or not even realize that you become even more difficult person in a bigger problem. So coming to the actuals of how we could simply start sitting down silently and trying to break through of how we can improvise the whole system for ourselves and then maybe help others is this one slide where if we try to do this as a single step from today, it might help, though there are larger things for wellness and how coping strategies are. But this slide really helps to just somewhere start or put a group into an activity where we can all make a difference. So coming to points like self awareness and reflection, so I think all of us have a logbook in each of our specialities, whether it's emergency medicine or the logbook for pediatric surgeons. We all have the best of cases which are written, and you have a description of how each case was, what is good about that case, and what could have gone better, or what are the best points of that logbook. So, in that same way, there is something called reflecting journaling. So reflective journaling is, I mean, anybody would want to explain or want to throw more words on reflective journaling? So it's simply, in other words, having a logbook. We all know logbooks for medical school, but reflective journaling is a similar logbook where we maintain when you have extremely difficult situations or experiences, you try to just put that down on paper. It's a very less common practice, or rather most of us don't do it because it just feels like, why do I need to put this on paper, and especially a private emotion where I don't want to put it on paper. But it makes a whole huge difference when you just simply try to put that experience or that emotion on paper, or for somebody it may just be with a laptop or a tab, but just putting those points down and then trying to see what is this emotion or experience trying to teach me. Simply asking three questions like what about this emotion is one thing you can have, whether it's a complication of a surgery, or you didn't behave well with a junior, or the junior didn't respect you enough. So it all has to be like, what is this emotion about? And next, the question will be, so what so, or it is like, so what? Like sometimes you have a defense mechanism because we're all humans, and we all, doctors especially, come with a lot of ego. I suppose that is very true. So we'll be like, okay, so I did this to a junior, I was very loud, I shouldn't have been, but still we go back with, so what? He was wrong, he shouldn't have done this. I was telling for the, how we justify that is, I was trying to tell this in the best intention of the patient. We justify patient there as, I can behave like this because I was telling the larger interest of the patient. But we less often realize that yes, despite of the larger interest of the patient, you still shouldn't have behaved or done this. So the question, so what, reflects, helps you reflect how you could do the same thing in a different way. And once you've addressed that, the next question, the third question will be, what next? So now that you realize, so what, you shouldn't have done this or should have done this, so what next? In case, however you reflect about it, what next do you do about the same thing? It's about predominantly reflective journaling. Another thing, this is an individual activity where you sit down and do it with yourself. The next thing is what we call the SWOT rounds, or this has come from the SWOT Society of Compassionate Healthcare. That's where the roots of it comes, is how we sit down with a group and try to concentrate on emotions. So I agree, you're all great surgeons, and it's not about the objectives of how the surgical step should have gone or what should have been the outcome of the surgery, but just doing a round with the whole team of whether the nurses or doctors or whoever is involved as to what is the emotion that has gone behind this whole procedure or this whole rounds or the healthcare system wherever you work. It can be different for different specialities, but just putting those emotions down, focusing on those emotions and trying to make it more healthy of how you can improvise the system is predominantly what short rounds thing. And Bayesian groups, again, Bayesian groups, I agree, at least I come from a medical college for my practice, so we all have our loud, a little discomforting mortality meets what happens, where each one is in a very defensive mode of, I'm the best surgeon or I'm the best physician, I have done this in the best of my clinical expertise, and that's how it goes. And it's quite difficult because now you have a mortality, it can't be any more pleasant. But again, having small group discussions or a one-on-one discussion where you still have a bad complication as bad as a death, but how you try to break those emotions of what the person defaulted, or how you try to talk the same thing so that the same thing does not repeat in a healthy environment can at times help, other than the academic sessions of mortality and other things. So the self awareness and reflection in these forms overall helps for a small team building. It may not change the whole perspective of the whole hospital, but improvising your smaller team of a group of surgeons or the it really works well for the ER physicians, because every single day I think we have a tiff with every other specialty. Not one specialty, but most of the specialties, because we have a lot of differences of how, again, ER is a very developing branch in India. And if it's a simple case of even pediatric trauma, I would have learned things a little differently and want to do that, whereas the pediatric surgeons or the pediatricians want to do it a little differently. Now, there's a whole difference in how each of us have to have learned, but end of the day, we have a common patient. So in those disciplines, again, these things really help in how we make a healthy environment. Coming to boundaries and balancing, again, it is not about learning to say no, but it is simply about each of our boundaries can be very different, and how exactly, instead of draining your whole self and where you can't provide any more from a draining cup, it's better to always preserve your own morals and to have a clear boundary of what is discomforting to you so that you don't drain too much. Coming to connections and peer support, again, this is a very one of the analogy I would like to give is every other day we have a code blue in the hospital which is running for cardiac arrest, and we default have a debriefing for code blue at the end of every cardiac arrest. But how many of us do a debriefing following emotional distress or an experience till date? So whether it can be at home as a family or at workplace, after cardiac arrest, we always have a debrief. But how many of us do it for the same things because we have a really bad heartbreak or an experience which should not have happened in the hospital? Any one of us as doctors? I don't think so. We really don't have debrief once we have a very difficult emotion that is running in the department or hospital, but it really works well. Again, we have different protocols of how we have breaking bad news and other things, but the same protocols can still be used for how you debrief a team for the same emotions. But the objective is different. You're not going for clinical practice there, but you're just breaking down emotions and what you could have improvised. So that really builds a good connection and peer system where you can actually have a very open discussion of breaking bad news, and indeed the system culture. So again, this is not going to come just by one talk of today, or just trying to set it for a few months. I think it's a whole cultural difference of how you be a very supportive leader and not do things what maybe have been distressing to you over the course of time, and team building, which is a long process to have been done. So, self awareness and reflection, boundaries and balancing, connection of peer systems, and a strong system building where it's a more healthy environment for people to be in case of healthcare professions is what we think. And coming back just to solitude, this one slide where each of that spoke about health as a in a healthcare setting, and this just speaks about how you could improvise yourself. So basically, again, reiterating whether you have a good nutritional practice, whether you have good sleep hygiene, whether you have good, where you go back to practices like your hobbies, or including things like going back to what you didn't do for a long time. For example, I learned to ride a bike for when I was young, but it's been quite a few years which I didn't even couldn't go back to doing. So just going back to what gives you joy, and instead of being lonely, the word we use is solitude, where you enjoy yourself. And one of the last things I would want to tell or reiterate before giving the mic to Sir is, if nothing of this works, because this whole thing again looks like a very one way talk where I'm trying to tell you something and it obviously wouldn't register with the one talk we try to give, and you can't make a system change all in a day or in a few years. But what really works for each one of us when we really fail is just sitting back and going back to thinking, reconnecting with the purpose. It's just again reconnecting with my first slide. where at the age of 18, each one of us had two beautiful dreams. That is one for professional life, how you want to be a very fine physician or a fine surgeon, and another beautiful dream for personal life where each one of us would have dreamt, I want to do this in my personal life. But if nothing works, just sit down and reconnecting to your purpose of what you started it for and how things failed, and just trying to make steps of how each one could be written down and improvise really helps in going a long way, where you just connect to your purpose. And it can be as simple as, or you can sit with a person and reconnect to what you want, what is your ethos of life. So thanks to a sir who's been like my mentor, and literally who could just, for example, I can tell you on my journey here, where sir could last evening, and who could just read out a chapter from the novel, the Jonathan Siegel, which is a 1917 novel. And one of the chapters, sir could just read out, and it's like a butterfly effect. Sir just read out one chapter, the chapter one of that, where it's written by Richard Bach, if I'm not wrong. And it's like a butterfly effect. You don't know what the other person is going through, but the fact that you just had a book and you read out something just reiterates people to connect to themselves, telling what is my ethos, why did I start this journey to be a pediatric surgeon, or in my personal life, what is that I want to do. And maybe they'll get a butterfly effect where they really do well. It gives them a takeoff from there to do far better, and you don't have to do it on a constant basis. So that's one thing where each one of us have gratitude and also have a helping hand to all those who in our journey. With that, I want to give the mic to sir for concluding. So this is reconnecting with the purpose. And just to reinforce again about the whole thing of talking about, it's we all have a load, we agree with that. We've gone through whatever we've gone through, each of us in our 30s, 40s and 50s. It's not that it's not the load that breaks us, it's literally how we carry it that makes a whole difference of how I look, or we all need to look at life as.
So what is the take home message? What are we taking home? That's how we end all our academic presentations, where you have a definite objective to take home. It is one message is what I want to leave you with. You fall down 7 times, because most of us, as we go along, there will be falls which will come out of choice of somebody else, or maybe out of no choice. But when you fall down 7 times, how many times do we get up? 8. No, you only get up one more time. You don't have to think I'm going to get up 25 times. You just have, if you fall 7 times, ek aur bar utna hai, only one more time. So if we focus on that, that is what resilience is to realize that only one more step I have to get up. And in fact, the take home message should only be this resilience. Easier way of showing resilience, I thought, was the spring, right? I hope we all become springy pediatric surgeons, and to keep this image in mind, because we can always bounce back, because the falls are definitely going to come. Thank you very much. Thank you, Dr. Sahana, for
Thank you,
really
sir.
taking us on that journey. And thank you, audience. I know it's the last talk of the day, but and I thank the organizers. We finished well in time. So, Chairperson.
Uh, uh, Very thank you, sir. I have opportunity of hearing your talk in second time, maybe within 3 months. Sir, one question from my side. So, do you have any personal tip for young surgeons like us? You know, before hitting it, like whatever it is, depression or anything. Do you have any personal tips to avoid it?
Yeah, I would go back to that slide which Dr. Sahana put up, where she put up those 4 things about peer support, journaling. Those are the ways I think we need to be able to. I got it. Yeah, I think that's this is what's probably what we can do and inculcate in our juniors when you're training them. And one big problem I have with the current training system in anywhere in the world, I think, not just in our country, is we spend those 3 years of training and teaching them. We are teaching them operative steps. Some centers we teach them good OPD skills, but we completely ignore this thing of preparing them for life. Because after we train them with operative steps, we throw them in the real world where there is many more challenges which they have to face. And as true mentors and parents in the professional sense, I think we should spend a little time as part of our 3 years training that we don't just teach them how to do a procedure, but also to be aware that this can happen. I think that in the training program, if it comes through at some point, maybe it's a dream, in 5 years, 10 years, it may come, then we will be truly in a mentoring role for our students. Otherwise, we'll just be academic teachers. We will be.
And that personally,
Dr. Antony, uh, I am hearing you for last 25 years. Vinde.
Sir,
Yeah,
Dr. Binde.
yeah. And was sitting beside me, and I was just making it out whether I'm seeing the same Antony what he used to be 5 years or 10 years before. But totally changed, man. Coming to the point and coming to the topic, the audience in this auditorium speaks about how reluctant we are to accept this reality. We are stressed. Being a doctor, a pediatric surgeon, and later on an administrator, uh, working for last 3 years. Sir, it is not only you, everyone, if you see in that perspective, has have their own part of trauma, the mental trauma especially, but we never realize it. We are going in the evening at home, we are loaded with baggage is full, and we are just burdened and going and then putting it either in the servants or family members. It is not one time affair. Many times we never know how to get rid of that. And this is the only discourse of what I found. What you were telling is, whenever I was going in last 10 years, when I realized it is not me who is operating and giving the success to the patient, it is the die, whoever and whatever he is, it is there. I am just praying after scrubbing my hands and putting hands above. He is drying up his hands, but my hands were there only to say that, sir, I am doing the God, I am doing my best. It is you who will heal him. And that gives bless and peace of mind when I am taking the scissor or knife to do something. That is one thing. And later on, I found everyone is practicing either physically open or they are doing it automatically deep inside. Everybody, when we are taking this out, those were different. When we were assistant professor, when the resident was just bubbling and going down. Later on, when you realize the whole reality, we turned spiritual. Coming to the point again, the question asked by the chairperson, I think it is spirituality. Spirituality is not religion. Spirituality is being in the place and in time and being in touch with everyone around and feeling their pain and just having empathizing them. This is the only way to move ahead. If there is a life, there is a pain. And if there is a pain, there is a way out. It's the noble truth of Lord Buddha. And it speaks out everywhere. Thank you very much.
Thank you, Dr. Binde. For those
Thank
of you
you,
who
sir.
don't know, Dr. Binde is a pediatric surgeon and also in a very high administrative post. He's dean. So it is really valuable listening to your words, sir, and it is so important to acknowledge. And I'm so proud that you're sitting in the front there and acknowledging it, especially for the youngsters, because it is something that is a reality. Thank you, sir. Sir,
Sir.
sir, yes, sir. Someone can please pass a mic to sir.
I just wanted to focus should also in why this has started. I belong to the era of late 50s. Never discussed why now. I have some reason to tell you, but that time study out in back in why we did not discuss. I got to my angle of looking at also study in a burnout. Burnout. Now there are so many articles. There is stress is why it is increasing. Now, not one of course governmental activity. Yes, pay. I hope you all remember there was no stipend turn or and then they started with it was in like left the also study and incorporate in your paper that it gives for the body as this can look into and prevent that.
Thank you, sir. Yes, Dr. Soundarya.
And Dr. is very important position to be started. Really nice to hear anecdotes because I think every young surgeon, at least, time you face a complex death, it's nice to know that you're not the only one feeling like that. But this is something I have thought about. One of the points that you mentioned was causes for burnout was something that I have thought about as well. That we are where we are death and not just child, death of a child that you have been a part of in taking care of the child. Problem is, he taught us how to process this death, and we are not teaching our residents. Next problem is, yes, sir, our days are jam packed. Go, go, go. Come in the morning, child who care of in post-op period, like very have an attachment, or relative, but you have a very attachment because child died. Have all of two get a call, run to have to have to get over it in that 2 minutes because you can't get over your emotion. Then you finish your OT, you finish your evening rounds, you go home and come back the next. So you have never processed this death within 2 minutes. I feel it kind of adds on. Eventually, like ma'am said, kind of probably become a do not disturb. But
Yes.
I don't know. So this is a problem that I found that nobody taught us how to process.
I'm learning from her talk and after her sharing from yesterday that reflective journaling is something that I have neglected completely. Dr. Mohan, I'd like your thoughts
My point
also,
was,
please.
should this be a part of our teaching
Training.
curriculum?
Yeah.
Because
Yeah.
because this is something that should be part of the curriculum. Otherwise, it will not get taught.
Fantastic. Let's raise our voices continuously. Somewhere it will come in the curriculum.
To just add to that point,
Yeah.
yes,
Uncle?
sir, I wanted to make
Yeah,
one.
you take it. Yeah.
Sir, please, the last points,
Yeah.
the mental health
The chair is speaking. Uncle.
the transition from a resident to being a faculty, especially in a new institute like all the aims we are in our early 30s, like 4 5 years within post MC. That transition is very important, sir. Like previously, we are in a institute, our mentors are there too. It's a very it's a safe background, the kind of bravery you feel like you go on operating, consultant is there, and that speed and that bravery is somehow uh, I'm from PJ, sir. Even I faced that challenge when I was independently handling those patients. Be it a very simple acute appendicitis, I must have done more than 100 or something in my residency. But still, the fear which we have to come across, what will happen, and all the complications they get on in our mind. So that has to be we should be made aware during our residency itself that you are going to be accountable for everything, right from a very simple procedure to every complex procedure. So the impact on our mental health and everything should be a part of our MCH program at
Correct.
least,
What Soundarya is also stressing about. Dr.
because
Mohan.
it is being introduced in MBBS
Yeah.
curriculum
Yeah.
and all this suicide prevention week, all these mental health programs are being introduced. Why not in MCH where we are?
It's a very good point. My worry about curriculum, the word curriculum is, I know when I was studying, medical ethics was being taught for the first time. I was in St. John's. That time it was not a subject, but it was a concept. It was very exciting. Within 5 years, it became a subject. And there are now exams for it. So it has just become portions, examination, evaluation of that subject, and it has lost its original point, which was Dr. Mohan, you've been training people for a long time. Right? It's just valuable to listen to your.
No, two things I wanted to add is one is for work-life balance or work-life integration. I think that's very important. Because one thing that's going to happen to us, especially in our career, we are so interested in our career and career advancement that we tend to forget the family. And remember, when you become old like me, it's not the patients who are going to be with you. Families. So what I used to do is, I integrate. The family becomes part of your workforce. In the sense that, when I'm publishing an article, I call my daughter to draw the diagrams. Not that I can't draw it, but then she feels involved in the whole. Then my wife is doing a difficult surgery, like she's a gynecologist. Sometimes I go and help. So it becomes a collective effort of the whole family. And in the end, we all go out for a vacation. Every now and then we take them out, we go out for a vacation. They don't feel, distance. I mean, there is no work-life separation. Joint family. Second point I wanted to say is, we all, as you said, when we took up this profession, we had that idea of a noble profession. And somewhere down the line, became service, a consumer and a service. And now the patients look at us as if they hired us to do a job. Like you hire a carpenter to do a job, at the end of the day, we don't thank him. So neither the patients. So that leads to a lot of disillusionment. Now I came into the profession because of that, but now where am I? So that is a problem. And as you said, I always say this in our also MC. There was my work is for a king. So I always remember that in mind. I'm not working for the patient, but I'm working for a higher, like you said, before you start the search. I mean, you make sure what you're doing. I mean, don't let either the patient's appreciation of you or your boss's appreciation decide your happiness. Your happiness should depend on what you're set out to do. Like, I want to treat this patient, I want to do this surgery. Your happiness should depend on whether you have done this correctly, not whether your boss appreciated it or your patient. So, as long as your happiness is within your control, I think this burnout question, as somebody said, why we didn't think about 20 years back? But it was not consumer and provider.
Yeah.
It was patient and sick. That is why we feel, even if we had a sleepless night, even if we are pauper, we didn't have money to go out for a picnic, but still we feel gratified because we felt we were doing something. That is not.
Thank you. Thank you, Dr. Mohan.
Yeah, exactly. That is what I wanted to say, sir. Like 50 years back, you didn't have mobile phones. You know, you were not looking for validation. You had real friends. You had real like connections with your family. So I think another box which I will make is maybe stay away from your phones. Like reflect and connect with your friends, peers. Stay away from phones and social media. I think that is taking away a lot of time.
Yeah.
And as sir said, we are looking for validation from others on that social media platform. So that is one. Second, what Dr. Soundarya was saying about when is the time to reflect. So that is also my question, that when everything is moving so fast, you have a complication and the whole team goes through a torrential time, and you go to the next case. So I think it's important to pause, stop, reflect, as you said. But I'll congratulate both of you for a fantastic talk, and I think it doesn't do justice the crowd here, and I think it should be put online. This is the most important talk of today, I think, from the morning. Thank you, sir. Thank
Thank
you
you
so
so
much.
much.
So I want to
Thank,
add one point.
Thank you, Ankur.
thanks, Robert. This is Gera from Perth. I think this is a really important point, and only yesterday I was reading this news from New South Wales, good train. 26 doctors committed suicide in last 5 years in New South Wales. And one of them was just a story that he took time off to go because he was stressful, burnt out. And then the workforce called him and said, when you are coming back, and put him on a roster where he was on night duty, not in contact with other people. And next morning he went home and he committed suicide. So this is a very complex issue where, as Ankur brought social media into it, that we want validation again and again, and we need to somehow support. I think the seniors need to step up and support the younger generation there to where work-life balance stops and where you can take work home or not. And it's really important to pause every now and then and reassess and reflect at what you're doing. Last week, I was in Auckland for a meeting in pediatric surgery, and while I was coming back after all this discussion, I saw this new movie known as a Mistake, and I will encourage all of you to find that movie. That movie was a surgeon making one mistake in theater and patient dying, and how that went into a big disaster. And the third thing in West, you have seen that if a patient dies, there is a lot of support around for the surgeon. At least the surgeon is journey, but we have a social other people, we have a surgery, mortality, a lot of people. It's not so much person comes kind of system focus, and I think that need to be brought. And I always say when you have a complex patient or complex thing, share the love, share the love with other specialties. Don't take everything on you. And of course, one said from all the praise and the respect and no, thank you. It was really
Thank you.
incredible.
I mean,
Thank
to
you.
just
Yeah.
add to that, sir, thank you so much about speaking for about seniors and being generous to other specialities. If I can make the room any more intense, you're all a group of pediatric surgeons, and I just want to ask, how old is your specialty and how established? How many number of years? Just want to know. So yeah, 52. It is. I think you'll hit a silver jubilee at more
Yes.
than that.
No.
Okay.
Yeah. Yeah. Yes. Yeah. So about 70 years you can
Okay.
look at.
So
Yeah.
I think 70 years is what you are all looking at, and you're still counting. If I have to just tell two words, I mean, or one word, and why this topic is so important and why I am here is I feel all of you here, including like even the juniors to the senior most, are blessed because you are 70 to 75 years old and established. Where I come from a specialty where every resident, including me when I was there, I felt like an orphan. This is the single most word I would like to use because the specialty of emergency medicine in India was established in 2012 and onwards. So it's only a special. I come from a specialty where it's only 15 years old, and at least you are telling I have a mentor. I want to break the bad news, learn how to break the bad news, and then maybe between surgeries we're like only go go go. So we'll pause. So for us, it is like even to teach the technical aspects of the patient or of the knowledge or the soft skills of how you reflect about life is still not established, but still it is a specialty of MD, emergency medicine, and there's a long way to go whether whichever branch you take. Why it is important to be good mentors overall is, again, there are a lot of students and faculty who are reflecting and seeing mentors in other specialties. So as a healthcare professional, it becomes extremely important. At least the pediatric surgeons have a whole system to where they can go and ask, whereas the other core specialties where the patient is the same, you have the same trauma patient in the ER, and you have the same age group of MD emergency medicine students and a pediatric PG and a MS general surgery PG. At least they have somebody to go back to, and the other specialties may not have that too. So adding it as a very holistic curriculum for the country is where it is really important, and that's precisely why I would also want, I would never say no to talk in any of the specialities or their conferences other than ER2, and that's how I'm here.
Ankur, just to complete what you suggested, saying that the number of people in the audience, but what I'm thrilled is I was here from the morning. The interaction which is generated among all of you, that's what makes it worth it. The intensity, like she said, in the room. And therefore, I'm really grateful that you brought it up. I think the interaction makes it worth it. Thank you.
So
Yeah.
thank you. So I want to add one point. Should we cope up with the stress with the young surgeons? Should spiritualism be introduced not only in MBBS curriculum but along with postgraduate courses and MCH curriculum? because that helps in reflecting
Yeah.
the own inside of.
I would be very careful answering that. I know Dr. Binde is no longer here because spiritualism is a very individual choice. A very individual choice. And the moment we institutionalize it, then it's like medical ethics being taught. Then it becomes institutionalized. So I think what we can drive home is the fact that spiritualism is the way forward. Spirituality is the way forward. That we can do on a one-to-one with our trainees, with our youngsters. That we can do.
Because recently they have said because of the suicides among the MBBS doctors, they are going to introduce spiritualism in the course MBBS curriculum. So why not introduce in post graduation? And
Anyone want to respond? I don't have an answer. Yeah.
Four walls
Yeah.
doesn't create. One says
no, I'm not talking about
I
religion.
understand that.
Yeah.
So the best the boss or the head persuade have some time of you have a religion
Yeah.
curriculum. Any curriculum for MCH has to go already in Niti Aayog says is have load head. Now they are trying to integrate both. They are also in confused, changed but not perfect as far as MCI will become
And
Russian. That's all it changed. But the basic problems are untouched. Then Madam has started a valid point. Rapidity. Expanded the number of there are 26 or 28 last month or 7 coming up. There the speed in which it expands. One point I have that is second point which I want to say that the speciality which for stress. I have one person in my lifetime I have been Pondicherry was later, but All India Institute I was incorporated in, I was involved in planning stage. Yeah. Number of workload, our population. Then internet created problem. Study and take your time. Operate, cooperative care. These are the points just the government. There's a pilot stress when one pilot lands 5 times, he's off. London or permitted landing. Whereas since I am an air, 5 landings, that's has to develop. Take time, process it. Regarding pilot stress and laborer stress, that they was some government want to make well the fight was so said that any suggestion CIF should first postgraduate is already 2 years in our time. Now 3 years. PhD. Like that, how much man is 40 or 50? Thank you.
We better wrap up with this last comment.
Yeah.
As these people will
So not a
close out.
comment, just a question, sir. I came late. I was in a workshop. So just wanted to ask now, any surgeon recently started operating 4-5 years. He has a mortality of some minor case because of unusual reasons. Let it be a hernia or circumcision, multiple intubations preterm. He has lined up next day 5-6 cases. And that trauma, mental trauma of a minor case going, how do you manage the stress for a next day cases?
In fact,
Being
I explained an anecdote from my own surgical career where I had a relatively minor case which died. And my teacher actually it took him 5 days to actually calm me down and get it back. The key to that is what you talked about, relationship with peers. You must have other people in our own profession, maybe in another city, doesn't matter. Like VVS is my very good friend. Sai Prasad is so any difficult case, little bit of debriefing. We are learning debriefing from these people is I think what is needed, because our own department we won't be able to debrief because there'll be too many politics involved. So I think it's good to have relationship and debrief.
And that's where the boundaries and rituals of closure really play a game. So basically, it's not well understood what you mean by boundaries and rituals of closure, each one to their own speciality or personal life. But you should have your own way of the two words you'll use. The boundaries of how there'll be a constant pressure from outside that you're asked multiple questions, but you still have to perform and prepare for the next day's surgeries, or your rituals of closure to just be like, I will put a line and a boundary here, or I'll put a ritual of closure that I will not discuss this anymore, but just wake up fresh and finish all those surgeries to just come back to this topic on a later date where I will make a technical sense out of it. But the most common thing is we think about it all night. There's no boundary, there's no closure, and operate with the same thought process. And so that conscious word meaning of how each one, you should write it down and be like, my ritual of closure for this for now is this, and I will come back to this on a later date. So it gives you that calmness that I will readdress it.
Thank you.
We'll wind up this session, sir. Thank you, Robert sir, and thank you, Sahana madam.
Thank you.
Thank you, sir, for this amazing session. I would just like to add, we are conducting a survey on burnout among surgical residents. It's there on the group. Uh, we request you all to kindly fill it up. This concludes today's session. Mahaprasad is arranged on third floor. We all request you to please join us. Sir, wait. Third floor. We have arranged Mahaprasad on third floor. We all request you to please join us for the same.